Alrighty, then we'll get going. My name is Nikita
Do
Lakomkin.
it.
I'm one of the complex mind fellows at SDSF, and I'll be giving our talk on adolescent idiopathic scoliosis. Try to go through everything systematically. We'll start with some definitions. I think when you talk about scoliosis, it can be a whole other language, even within medicine, within spine. So we'll go through that. We'll talk about the prevalence, the pathophysiology, and how this comes to be, and then the different major classification systems that help us both describe this and prescribe treatment. So I think it's very easy to lose the forest for the trees here. So before we go through the trees, we can take a step back. Idiopathic scoliosis is really one of several possible flavors of scoliosis, the others being congenital, neuromuscular, and syndromic. And those are really unique, both in terms of describing it and in terms of treatments. I'll just briefly touch on it here. Neuromuscular scoliosis can be secondary to a whole host of primary diseases, including Friedreich's ataxia, SMA, Duchenne's, and mild dysplasia. Congenital scoliosis is really a defective formation or segmentation of the vertebral bodies, which can result in deformity, including wedging and hemivertebra and other types of problems. So when we go back to the trees, idiopathic scoliosis is described in numerous ways depending on the age of the patient. There's infantile idiopathic scoliosis, which is described from birth to 3, and a lot of those resolve without surgery. There's juvenile idiopathic scoliosis from ages 3 to 10 years. And there's adolescent idiopathic that we'll be talking about here. That's really described in folks from 10 to 18 and represents the vast majority of AIS cases. So scoliosis is really defined by having a Cobb angle greater than 10 degrees. Anything less than that is typically called a spinal asymmetry. In terms of prevalence, there is a significant difference in terms of sex, and patients who are female have greater rates of AIS. And this actually increases depending on the magnitude of the curve itself. So it's a 1.4 to 1 ratio in folks with a curve between 11 and 20. And it actually goes up to 5.4 to 1 for folks with curves greater than 20. And even progression, in terms of looking at progression of these curves, female patients tend to progress more. Pathophysiology is still really being elucidated. A lot of folks will describe this as a lengthening of the anterior column, but it's thought to be secondary to a whole host of different components, including genetic issues, proprioceptive, inflammatory, and these vertebral bodies really rotate towards the convex side of the lateral curvature, and the rotational changes are greatest at the apex of the curve and then slowly start to diminish. We'll take a look at that in the definition section. Spinal processes frequently become rotated, and the resulting rib prominence that you see is actually responsible for a lot of the cosmetic issues that our patients have. In terms of curve progression, it is really important to think about risk factors because that's really what guides treatment. So several factors have been associated with curve progression. Patient sex, like we just talked about, remaining growth, and we can kind of extrapolate using different markers, the magnitude of the curve and the pattern. And then folks with curves less than 20 degrees have a low risk of progression. When we talk about risk factors, patients who are female is a risk factor. And then skeletal maturity, which we can really extrapolate through numerous staging systems, including RISR, hand and wrist skeletal maturity, medical status is crucial, and peak height velocity. And the magnitude of the curve, of course, really helps drive predicting both progression and treatment. So the RISR classification we all use in clinic, it's really the level of ossification of the iliac crest apophysis here. So 0 and 5 look the same, and slowly as this apophysis becomes fused, you can see it start to fill in lateral to medial. And it's one of the key markers of skeletal maturity when we think about risk for progression in the curve. We can also look at the triradiate cartilage, and then the Sanders maturity scale. Our folks, our patients have their hands up in the X-ray machine. Those can all be used as markers to evaluate these patients. I'd be remiss if I didn't mention bracing before we get to classifications and surgery. Bracing is really a key component And one of the landmark papers is actually published by Dr. Weinstein, who's at the University of Iowa for many years. And they did a randomized trial of bracing. They actually also had a preference arm looking at bracing as an intervention in patients with AIS, which they defined as a COB of the largest curve being between 20 and 40 degrees. And they demonstrated that bracing was more effective than observation. Their primary outcome was curve progression. So if you got to 50 degrees or more, you were considered to have failed. And then they did a sub-analysis of the number of hours patients wore their brace, and they showed that folks who wore it at least 13 hours a day had a success rate of at least 90%. This is a very powerful paper that we quote a lot in clinic, and we counsel our patients in terms of treating them when their curves get to that 20-degree range.
What number do I typically use in clinic?
25 to 20, 25.
No.
Hours
How
of
many hours?
bracing?
23 hours?
Before 30.
I say 14.
Oh, really?
Yeah, because the kids always cheat. So you so don't tell them 13 because they'll work for 12. You know what I mean?
Yeah, they're probably 14, and the data is just under.
They're probably cruel at HSS because I mean, like, we'd be 23 hours.
Oh, really?
You get 1 hour break.
Yeah.
So kind of jumping to the nitty-gritty definitions, there's a whole number of different markers that we use in classification systems. So the upper end vertebra is the vertebra in the cephalad direction from the apex, of which the superior surface is the most tilted. So that's what we'll be using in our COB measurements. The apical vertebra here, so when you drop a line from the sacrum, it's the vertebra that's most deviated lateral. We talk about the apex of the curve from that central sacral line. And then conversely, the lower end vertebra is the vertebra in the caudate direction from the apex, whose inferior surface is maximally tilted. So that's very critical when you start measuring COB angles, which is really the building blocks of these classification systems. The neutral vertebra is something you think about in the axial plane. We mentioned that patients with AIS have rotation, especially near the apex. So the neutral vertebra is one that doesn't have axial rotation and is located on either side of the apex of the curve. So the pedicles are equidistant from that lateral vertebral body wall. Stable vertebra is the first vertebra below the lowest curve that is perfectly or almost bisected by that central sacral line. And so the first really systematic classification scheme that was widely adopted was published by Dr. King. And this was based on a review of patients treated actually by Dr. Moe, who Dr. Agbarnia tells us a lot about, with Harrington rods. And really the goal of this was to develop descriptive criteria and identifying patients who are getting these fusions. So King classification really rests on the stable zone of Harrington, which is bound by these two vertical lines drawn through the lumbosacral facets. And the premise is that this classification describes patients and helps you identify the stable vertebra within this zone that can be targeted as the LIV. And Dr. King talks about this flexibility index, which is used in subsequent papers to try and develop plans for these patients in terms of surgery by identifying which curves are more flexible. And so the more positive this index, the formula is right here, the more flexible the lumbar curve, and the more negative, the more flexible the thoracic curve. And that's employed in the actual classification scheme. So King type 1 is a double curve. Both curves cross the midline, and the lumbar curve is larger and stiffer than the thoracic one based on the previous calculation. King 2 is a double curve where both cross the midline. The thoracic curve is larger and stiffer than the lumbar curves. And then as you progress along the classification, you have type 3, where you have thoracic curves that cross the midline and lumbar curve does not. And then type 4 is where the long thoracic curve, where L5 centered over the sacrum and L4 tilts. And then there's a 5-2, where the thoracic curve in T1 tilts to the upper curve right here. You can see the shape. And subsequent papers have had to try to develop treatment recommendations based on these descriptors. And the recommendations were to fuse both curves of the lower vertebra for type 1s, selective thoracic fusion to the lower vertebra that's neutral for type 2s. For type 3s, it was fusing the thoracic curve to the level that's bisected by the CSVL, which we talked about as a stable vertebra. Type 4 was fuse the thoracic curve to the stable vertebra, and type 5 was fuse both thoracic curves to the stable vertebra. One of the challenges with the initial King classification, although it was the first and sort of major descriptor of this, is that it did not assess the sagittal plane at all. And so we'll get to talking about the Lenke classification, which really built on this. And then on top of that, it was really a descriptor, sort of a qualitative measure. People did try and develop treatment criteria, but it was initially really designed to group patients with these different curve types. And different follow-up studies looking at these patients showed that a lot of them did have some progression and decompensation in their lumbar curves. And so the idea was that there could be a more robust, more kind of inclusive classification system that could really be focused on guiding treatment decisions for these patients. And that's where the Dr. Lenke's classification comes in for AIS, which is really a landmark paper in this specialty and has been for decades. We were just in New York, and everyone still uses this to this day. And sort of the goal of this was to describe and group many, many curve types into 6 different general curve types based on Lenke. And then he used different modifier criteria to look at the position of the apex and then actually the thoracic sagittal profile, which you just talked about, which the classification did not include. So we start to go through it and we look. The first is to look at the location of the apex, and we split the spine here into thoracic, T2 to T11-12, thoracolumbar, T12-L1 at the junction, and then lumbar, which is L1 to 4. And this criteria looked at major and minor structural curves. So the major curve in Lenke classification is the one with the largest Cobb measurement, and it always has to be structural. The second curve is the minor curve, and it's structural by definition if on side bending films you had at least a 25-degree curve in the proximal thoracic, main thoracic, and thoracolumbar spine. If you think of that classic S-shaped curve. This is, I call it the Mundus touch. So Dr. Mundus will draw this out in the operating room, and I actually think it's an easier way to memorize this because you really should know this by heart for treating these patients. So very simply, Lenke 1 through 4, the main thoracic curve is the major curve. And then every other type 1 through 4 is a play on this. So type 1, there's no other structural. Type 2 is proximal thoracic. 3 is thoracolumbar lumbar, right? The 2 possibilities. And 4, it's MT, proximal thoracic, thoracolumbar, so you have all 3. And similarly for 5 and 6, the thoracolumbar lumbar is the major curve without a counterpart. And then 6 would be thoracolumbar lumbar with a main thoracic. And of course, we can't have a thoracolumbar lumbar with just a proximal thoracic. Doesn't work. Modifiers are another really key component of this. So Dr. Lenke describes lumbar spine modifiers, type A, type B, type C, and that really revolves around looking at the position of the central sacrovertical line to that lumbar apex that we talked about. And so it's type A if it's between the pedicles, B if it touches the apical bodies, and C if it's completely medial to this. It's a little bit easier to see here in this breakdown. So in the modifier A, you can see the apex falls between lumbar pedicles. And it has to be medial to the medial pedicle wall. If it touches the medial pedicle wall, then you're going to be. And this includes the king types 3, 4, and 5 that we just saw. Lumbar modifier B has a CSVL that falls between the medial pedicle and the lateral vertebral body. And then conversely, C is where that line actually falls totally outside of this. So you can see the 6 different curve types with the different lumbar modifiers and how you can see with this one classification system, you can describe many, many, many different types of patients. And finally, thoracic sagittal profile, Dr. Lenke described as having a hypo, meaning less than 10, normal, 10 to 40 degrees of kyphosis, and hyperkyphosis, which is greater than 40. And the real power of this system and why it gives so much value in thinking about these patients is it really helps you determine treatment. So when we kind of work through all this, because it's really a lot to wrap your head around when you're first starting, is step 1 is determine which curves are structural. And so that's where the bending films come in. The structural curves give you your classification because you can go back to that table and group them 1 through 6 with the appropriate modifiers. And then you know that typically those structural curves are included in your fusion. Step 2 is you think about where to pick your UIV. So if you have a proximal thoracic curve that's structural on the benders, you're going to go up to T2. If you don't have a structural proximal thoracic curve, then you're going to think about the shoulders of the patient. And if the shoulders are even, the classic UIV is T3 because you don't need to do a lot of corrective maneuvers. If the left shoulder is higher, you typically go up to T2 because you'll need to do compression distraction maneuvers in order to get those shoulders level at the end of the case and to help you. Conversely, if it's the right shoulder that's up, you can typically stop lower because when you correct the curve, you're going to level the shoulders in the process. And that last step is to think about the LIV. And that's where we use the lumbar modifiers and the flexibility of those disc spaces. And classically, the last touch vertebra is typically a good stopping point, but we'll talk about selective fusion in a second. And then for curve 6, you're going to fuse both. And for curve 5, you want to include thoracolumbar. One of the things I talk about with Dr. Mundis too is the goal of selective fusion, because ideally the goal is to fuse as little as possible to preserve the maximal amount of motion. That's a little bit tricky because you're balancing that with your alignment goals. And so there are a couple tools you can use to identify the patients for whom it would work. And there have been a couple papers talking about something called the apical vertebral translation, which is a distance between the apical vertebral body and the C7 plumb. And then the AVR, which is a vertebral rotation that was talked about by actually Dr. Nash and Dr. Moe, which is a grading scale. And if your ratios of those between the main thoracic and thoracolumbar curves are greater than 1.2, or your thoracolumbar or main thoracic to TLL Cobb angle is greater than 1.2, those patients can be potentially a good fit for selective thoracic fusion. A lot of times you think about Lenke 3s, and there have been a couple of papers that have published that have been successful in treating those patients with a more limited selective fusion and preserved motion. And here are my references here. Thank you so much. It's a very busy time.
Gentlemen.
Sorry, yes. One thing I was thinking about is like with Lenke classification, how do you rectify that with like Rousseli type 2, right? Or types in general. I mean, I feel like when you have the like coronal plane deformity, like we often see subsequent deformities in the sagittal plane too. And it's like, it can be confusing, I think, to also kind of like wrap your head around that too, especially when you're thinking about your reduction maneuvers. And, you know, Dr. Kelly likes to talk about how, you know, derotation is a hypokyphosing procedure, right? So it's like, how do you like wrap your head around that? Like, you know, I want to maintain adequate spine shape because I'm thinking about the patient 30 years from now who may have sagittal plane decompensation, but also, you know, get an appropriate correction in the curve.
Answer it.
Yeah, I think
Think of extremes. Think of a type 2 versus a 4.
right.
Both of them with a 60-degree main thoracic, a Lenke one.
Yeah.
Like, how does that help you and what you ought to do? Let's say you're trying to do a selective thoracic fusion on it, right?
Right.
You have to stop at, you do a T4 to
So you just have to be careful then where the apex of your lordosis, or you're thinking about where your apex of either the thoracic kyphosis or the lordosis is going to be, because that's going to differ from Rousseli R1s and R4s. So at least that's maybe how I would think about it. But
and then for 2, you can derotate more technically. So yeah.
And then for 2, you want them to be flatter in the thoracic spine anyway. So on those, you can probably go gangbusters with it.
Yeah.
Right?
Yeah.
And you just have to be mindful for the 4s.
Yeah.
Do less.
Where I think it gets tricky is that, you know, the teenagers, they may not have their pelvic incidence dialed in totally because they're not skeletal maturity. So in those, you know, I think there's a larger gray zone where we're using the PI to determine Rousseli type.
Right.
But the reality is you may not be able to change their incidence when they're 13. So that's probably why we don't see such horrible sagittal plane deformities in kids earlier on when we clearly flattened them or clearly changed their R type.
Mhm.
Maybe because it's modifiable.
Mhm.
But your point's a really good one because this classification predated our understanding of the sagittal plane by 15 years when you're talking about in terms of employing our type with T4PA, L1PA.
Mhm.
And now Dr. Lenke was saying in the meeting, he's using those and he's using
Yeah.
prevent rods to
Right.
control the sagittal plane.
Yeah.
This was a big step up from King, like we talked about yesterday, in terms of including the sagittal plane. But
Mhm.
our understanding has evolved a lot in the last 10 years, even the last 5 years. You go to these meetings now, there's a huge emphasis on the sagittal plane.
Mhm.
And so you're right, it's moved beyond just, greater than 40. And something to think about.
The other question I had to Dr. Mundis is,
So just to hold your question real quick.
yeah,
So then the other one is to go down to your 5s and 6s.
yeah,
You think about the sagittal plane down there and what you're doing to these selective thoracics from T10 to L3, which is a really common area to fuse in kids. And
yeah,
as you guys have done some of these with me, they're super flexible.
right, yeah.
Those orbital lumbar curves, I mean, you can
Dissect in there.
yeah, I mean, by the time you have dissected the sets around, like the spine's almost straight, right?
Yeah.
Like, so on them, you can almost manipulate the spine however you want.
Mhm.
So there, I think we're thinking a little bit differently on those,
Mhm.
because the thoracolumbar junction, which has historically been fine to straighten out all the way, like the classic teaching is T10 L2 should be straight, should be 0. That's because a lot of type 2 patients, and that's
Right.
kind of what we thought.
Right.
But the reality is that's, over 50%, maybe 60% of patients probably don't demand that. They probably demand something different.
Mhm.
So to start thinking about like what you're trying to create across that, and maybe you need to add a level on one of them, maybe
Mhm.
you do less. I don't know. I'm just saying, like, we are rethinking how we do that surgery for sure.
Yeah.
Because you can sculpt that spine however you like,
Right. But
with rigid adult.
I guess that kind of leads me to my next question because so Josie gave that talk about looking at like adult, like the last touch or stable vertebra in adult scoliosis patient, idiopathic scoliosis patients. And I'm curious is, she said that like even in kids, like when they like stand versus when they're supine, they'll have changes in what that vertebrae is. How do you kind of apply that into your practice as well too?
So some people I like them. I like it standing
Mhm.
as my dominant one. I have several partners in that circuit that enjoy the supine ones better.
Mhm.
But I think standing is the real story.
Mhm.
That's what their spine's doing with gravity.
Mhm.
So I would typically employ that as a reference because the spine's going to buckle below it with gravity,
Mhm.
and you can't predict that based off of what they do.
The supine.
Which usually means you have to add a level.
Yeah. Yeah.
But I mean, if it's like between L5 and L4, I'll probably pick L4 and gamble, right?
Right.
Between 2 and 3, I'd probably pick L3.
Yeah.
Just to
Be safer.
be safer, yeah. Any other questions online or in person?
Studies looking at L4 and T4PA and breakdown or DJK in the adolescent population, right?
I was just thinking that maybe we should. I'm sure Mike's probably working on
Well,
just a part of it,
The whole classification thing. It probably wasn't as evident back in the days where X-rays were really all we did.
Yeah.
And we see it a lot more in adults because they degenerate in the setting of this longer standing idiopathic. But I always think of it like congenital. It's the sacral stuff, the sacral asymmetries that create a lumbar curve that's compensatory. They get compensatory thoracic curves. That sort of gets lost in the shuffle, and yet that's a pretty recognizable etiology that we sort of lump in idiopathic.
Yeah, that may not be.
But I don't think it is. I think it's structural.
what do you mean sacral stuff?
If you have a patient with a sacral asymmetry, or probably is asymmetric, they have a compensatory lumbar curve their whole life, or their head would be
Way over, yeah.
So they have this curve that is congenital, really, in its foundation. You follow me?
Yeah, I just wonder, like, if that's. I feel like there's a paper on that I read on.
But I don't know that it's ever been accommodated in its classification.
Oh no.
Right.
For instance, if you have someone with a 15-degree sacral dysmorphology for whatever reason, right? And then they have a lumbar curve and a thoracic curve on top of it. And you fix this. Like you can't, or this down here, you can't ignore this.
Right.
Because if you make this person straight down here, they will always
Right.
go off
Yeah.
to the left, right? Make sense?
Yeah, yeah.
We've always talked about pelvic obliquity or limb length discrepancy, but there's actually a sacral dysmorphism.
Mhm.
Probably part of a lot of these lumbar and thoracolumbar curves.
Yeah.
Standard practice.